Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Welcome to today's Journal Club. I always like to thank ESGO and IGCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's session, and the recordings will be made publicly available. Participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in our chat to our technical support team. Definitely, we will have time for questions and answers, and definitely encourage everyone to submit questions via the chat function throughout the session today. So coming on again to the Journal Club for today, really excited. This month's lead article is Endometrial Carcinosarcoma Without Myoinvasion by Giuseppe Cucinella from the Mayo Clinic Department of Obstetrics and Gynecology in Rochester, Minnesota, and then now currently at Pascale Institute in Naples, Italy. And also another dear friend and colleague, Mary Leitao from Memorial Sloan Kettering Cancer Center in New York City. And we're really, again, very, very excited to have you both join us for the Journal Club. I want to thank you for being with us today and sharing some of these insights on this lead article. So I'm going to hand it over now to you. I believe Giuseppe is going to be doing the presentation, and then we'll get started with our questions. So thank you all once again for joining. And Giuseppe, looking forward to your presentation.
Thank you for the invitation, for this opportunity, and thank you to everyone. Before starting the presentation, I will just spend a few words on these slides, and I want to thank all the co-authors of this project, this paper, all the PI from different centers for making this project possible, and for sure I want to thank Dr. Leitao as a leading author of this article. So thanks for the guide and during this journey. So let's start talking about endometrial carcinosarcoma. And as we know, it's a rare entity, and most of the time, I don't know if the slide is going on. Let's try one more time. Okay, so when we talk about carcinosarcoma, we know that it's a rare entity and most of the time is identified as advanced stage disease. So when we look at the early stage, we have very limited data. And moreover, when we look at patients with endometrial carcinosarcoma without myoinvasion, the data in the literature are very, very scarce, and we don't really know the outcome of these patients. Taking it to trying to address this gap in the knowledge, the objective of our study was to assess the long-term outcomes of these patients. So patients with uterine carcinosarcoma without myoinvasion. So 3 types of tumors confined to a polyp, tumor confined to the endometrium line, or with no residual disease in the uterine specimen after the hysterectomy. We conducted these multi-institutional prospective studies. We involved 11 centers worldwide, and as I said, we identified the patient with stage 1A, 2029 endometrial carcinosarcoma who underwent surgical staging with hysterectomy, bilateral salpingo-forectomy, and all of these patients underwent lymph node staging with sentinel lymph nodes or full lymphadenectomy. So we had 97 patients with this type of tumors, and 14 were with the tumor with no residual disease in the hysterectomy, in the uterus. 29% were with tumor confined to a polyp, while 65 were in the endometrium line. Then, as we say in the treatment, most of them, about 50%, receive chemotherapy, while we have also patients such as 16% who receive just observation or receive vaginal brachytherapy, like 14%. So looking at the outcome of these patients, we found a rate of recurrence of about 30%. 29 patients had a recurrence, and as we said, most of these recurrence were with a distant spread. So 15 were in the peritoneal carcinomatosis, 6 with lymphatic component, 3 with hematogenous component, and just only two had only vaginal isolated pathway. So most of them were with a high prevalence of distant spread of disease. Going to the outcome of these patients, so the Kaplan-Meier curves show that the recurrence-free survival on the left side of the left part of the slide, the recurrence-free survival was 63% and overall survival was 72%. Then looking at the right part of the slide, we tried to find a subcategory of this tumor that may have a better prognosis. So we try to understand if the tumor confined to the endometrial or in the polyp or in the with no residual disease was different in terms of prognosis. And as you can see from these two Kaplan-Meier curve, there is no difference in terms of RFS or S when we look at the tumor status. Then, if you look at the bottom part of the slide, we grouped the patients by receiving or not chemotherapy. And so we had 58 patients with chemotherapy and 35 without chemotherapy. And we compared the outcome of these patients. And if you can see the graphs, even if they are not statistically significant because the p-value was 0.08 for RFS, 0.07, is visible that there is a difference, even if it's not statistically significant. Patients with chemotherapy had a better RFS and OS with 67% and 78% of overall survival. Even if we want to be clear, there is no statistical significance, but maybe this difference is not reached due to the small sample size. So going to the conclusion, then we have time for the questions. Patients with carcinosarcoma in figure stage 1A without myelinvasion have a high risk of recurrence that is about 30% with a tendency toward distant spread. And the chemotherapy as adjuvant treatment did not achieve a statistical significance, but as I said, this may be limited by our small sample size. And so this is just if you wanna scan it for listen also our podcast, and thank you for the opportunity of being here. I thank you for everyone.
Well, Giuseppe, thank you so much for that presentation. Again, congratulations to you and all of the authors from these multiple centers. We'd love to start with our questions. We have questions from our fellows, and then definitely want to encourage questions from all of the participants who have joined. So first, we'll go to Toulouse, France. Mathilde.
Thank you very much for your presentation. Giuseppe, how did you select the participating center for the study? And were there any required quality criteria? For example, a minimum number of patients treated per site? And from a surgical perspective, do you know whether any preventive safety measures were implemented during the procedure, such as prophylactic coagulation of the fallopian tubes or vaginal stapling to reduce the risk of peritoneal dissemination?
Yeah, well, thank you, Matilda, for the question. We selected referral centers worldwide, and all of these in each country are very recognized as referral centers in USA, while in Italy or in other countries. And when looking at trying to answer to the other question on the surgical perspective, we don't have the data about the procedures such as the no vaginal cuff or the coagulation of the tube during the surgery. And also maybe we can also do another journal club on this topic. It's a very controversial topic, so there is no clear evidence that it makes a benefit for the patients to do these preventive maneuvers. So we didn't decide to not collect this data at this point, but it's interesting. Thank you.
Thank you, Giuseppe. And I think, again, Mario, would love to hear from you at Memorial Sloan Kettering. Are you routinely doing anything differently in terms of your surgical approach when you know ahead of time that you have a carcinosarcoma? So in other words, as Matilde was mentioning, coagulating the tubes, not using a uterine manipulator. Can you give us some thoughts on that?
You're muted.
Sorry, yes,
Mario,
You're muted.
we cannot hear you.
Oh, I thought that was a good thing. You can't hear me.
For most circumstances,
Yeah.
yes, but here we actually want to hear your answer.
So yeah. So yeah, we don't do any of that stuff here routinely. I mean, my thoughts on all this, people just kind of say things that should be done based on just opinion. But if you actually sometimes use a little thought and common sense, you realize maybe that isn't as important. So coagulating the fallopian tubes, I know folks have been doing that, especially for higher risk cases. But, we do hysteroscopy when instill saline, hundreds of cc's of saline during a hysteroscopy, and don't ever worry about that as being an adverse problem. And that's how many of these patients are diagnosed. But to do a hysterectomy and if you can do it well, I mean, you're manipulating the uterus for 30 minutes during a simple hysterectomy. For some reason, it's important to coagulate the tubes for that process. So it doesn't make sense to me. Also, the tumor is contained in the uterus, so there's really no reason to have to sort of staple the vagina or close the vagina off. It's unlike cervix cancer. Now, if there's gross tumor on the cervix for the rare stage 2 endometrial cancer, yeah, then it might be a good idea to make sure you don't expose tumor to the peritoneal cavity. Also, you usually try not to, when you do the hysterectomy, just rub the cervix along the peritoneal surfaces either. So as soon as you've done your colpotomy, you pull the specimen out right away. So, I mean, those things are all probably what matter most. And when there's a tumor that's within an organ, it makes no difference to coagulate tubes and staple vagina or do vaginal closures over the cervix. And, having said all that, we've actually looked at our high-risk cases of all types, including carcinosarcoma, and looking at MIS versus open. There's no difference in outcomes whatsoever, not even a hint of a difference in terms of local recurrence. And in open surgery, we don't coagulate the tubes. We don't close the vagina over the cervix either. So, it's not a direct comparison of MIS with containment methods versus not. But I mean, if it's the same outcome open as MIS, you kind of have to assume that doing all those other things probably makes no difference since we don't do those things in either approach.
Great. Thanks, Mario. And the next question, I think, obviously it's a question that we all have in our minds as it pertains to what do we do with these patients and how should they be treated. So we'll go to Tommy Meschini at Filippo del Ponte Hospital and University of Insubria.
Thank you so much for your presentation and for the amazing article. And I want to ask you, according to previous ESGO, where no treatment or only vaginal brachytherapy was usually recommended. Yet in your study, over 50% of patients receive adjuvant chemotherapy plus minus brachy. How do you explain this discrepancy and which clinical factors most influence adjuvant treatment decision in practice?
Just let me know if you want me to take anything, just because I'll take it all, but.
Yeah, okay. Well, looking at and trying to answer to the first explanation, so try to why there is this discrepancy in the adjuvant treatment of our cohort. Well, it's also, we should say that the decision was based on the standard of care and physician preference of each centers, and we have 11 centers worldwide. And also we need to consider the range of time this patient were treated from 1999 to 2023. But, well, I want to say that in practice, NCCN guidelines also in this type of patient recommend chemotherapy. So it was intermediate risk in the ESGO guidelines, and also but there is things that we need to say also in the 2025 ESGO guidelines. They say that there is no clear evidence and data to recommend the treatment for this type of patient because there are very limited data. So I'd say that maybe the factor that most influence the adjuvant treatment in the practice are, in this case, the histology, the carcinoma histologies, and sometimes the addition or not of radiotherapy, as NCCN said, depends on the sarcoma components and on dominance, and if there is a high-grade component in terms of carcinoma elements. So in that case, also NCCN recommend to add, while chemo and vaginal brachytherapy are standard for these patients. I don't know if Dr. Leitao wants to add something.
Okay, yeah. So first off, I'm just going to state that I don't use ESGO guidelines because I'm in the US. So NCCN's our guideline standard. We're a part of the NCCN as MSKCC. So I don't even really read ESGO guidelines nor really follow any of those. So that's all I'll say about that. So, carcinosarcomas, we have traditionally treated with chemotherapy essentially, and all the trials in carcinosarcoma have been all chemotherapy alone trials. None have required radiation. So really these cancers require chemo primarily. You can debate the role of radiation all day long, but radiation has never made anybody live longer. It only maybe impacts local control. Now, for a while there, we actually thought that we could avoid treatment in these carcinosarcomas without myoinvasion, because in serous carcinomas without myoinvasion, we noticed that, and we're about to publish something that shows that in those who have no myoinvasion, normal and negative washings, surgically staged serous carcinomas, they do not require chemotherapy probably for serous. And then for the clear cell, we're probably over-treating a lot of the clear cell. So because of that, for a while, even here at our institution, our guidelines suggested that if you had a carcinosarcoma without myoinvasion, negative washings, negative nodes, that maybe you did not have to treat those cases. So that's why there were cases that were untreated. There was always this back and forth. I think that our data now helps to sort of, I think, solidify the need for chemotherapy despite the negative P, the more than 0.05 p-value. We can talk about that later. So again, don't get too confused with these things in terms of intermediate risk, high risk. Those things are very arbitrarily decided upon by ESGO. There's really no science behind an intermediate risk should get that versus this. Those are highly opinion-based things. And the NCCN actually is more flexible, recognizing that there's no one answer for all these cases. So if you look at the NCCN guidelines, a stage 1A case, it is recommended to give systemic therapy plus or minus radiation. And our standard here, just at MSK, is all carcinosarcomas get chemotherapy with vaginal brachytherapy primarily.
Excellent. So, Mary, I think you might have already answered some of the next question, but I'll let it go to Carlotta Savini, Ospedale San Raffaele in Milano.
Yeah, thank you so much. You have already answered partially the question. So yeah, but still, is there a subgroup of patients with endometrial carcinosarcoma without myometrial invasion for whom you will still recommend adjuvant therapy? And if so, what type of treatment and on which clinical, pathological, molecular features would you base that decision?
So for this specific, for carcinosarcomas, pretty much every carcinosarcoma stage 1 should be treated with chemotherapy, even the non-invasive ones. And we tried to see if it was like no residual cases, like we took everything out, no any polyp, just confined to a polyp versus just in the lining and the endometrium, and those all did the same. And they all benefit from chemotherapy. So I think a carcinosarcoma is a high risk histology, and it requires systemic therapy because the pattern of recurrence is mostly distant and not pelvic or local. So all those patients now, molecular, we don't know. About, I guess, carcinosarcomas is about, I'd say maybe 50, 60% are P53 abnormal. But the other groups are also represented, right? MMR deficient, as well as POLE. There's a few POLE cases that we have in our database. And then what's the other group? There's P53. Oh, and then the other one that's whatever else, we don't know, that non-specific and one, whatever. That's like a garbage basket for we don't know. And honestly, we have to be very careful, right? And you guys are all very young and starting off. You have to be very careful sort of jumping with this molecular information to make clinical decisions. There's zero data, honestly, to support any change in treatment based on molecular patterns in stage 1 or 2 endometrial cancers of any type, period, end of story. There is zero data that you should treat one cancer one way and the other a different way based on molecular profile. Now, you can look at, for the advanced stage cases, MMR profile might lend you one way, HER2 new status another way, but you have to be very careful right now to use any molecular information to justify treatment, okay, or avoiding treatment, because we don't know that a POLE carcinosarcoma actually does well because most of them have been treated. right? Maybe the treatment, maybe they're doing well because they've been treated, right? So be very careful, and you should not use molecular information to decide on treatment currently in stage 1 carcinosarcoma specifically, this was about, and definitely not in staging patients. Anyway, that was digressed.
So, to follow up on that, one of your favorite topics, Mario, fecal staging. So Masha Pervin from the University Hospital in Münster, Germany, will ask the next question. So, Marsha, Masha, be careful how you frame it.
Yeah, well, I hope you can hear me well. It's quite loud. I'm sorry.
And if we can ask,
Concerning,
Masha, before you start, if we can ask everyone to just mute your microphones, so that we can hear the questions and the answers, that would be great. So, Masha, yeah, you're next.
okay, so concerning the group with the positive peritoneal cytology already at this very early stage of this disease, and half of them recurring at the peritoneum, albeit adjuvant treatment, how do you value these results in the context of the current fecal staging system that does not require peritoneal washing since 2009? And do you think the positive peritoneal wash cytology warrants extensive adjuvant treatment with chemotherapy and external beam radiation and maybe also therapy?
Well,
Yeah.
okay, let's try.
Perfect. Very well. Okay, good. Yes. So,
Well,
to hear the question in full, Giuseppe and Mario.
It was
yeah,
a little lot of background noise. I couldn't hear everything in detail.
Yeah, so I'll read it. Concerning the group with positive peritoneal cytology already at this very early stage of the disease, and half of them recurring at the peritoneum, albeit adjuvant treatment, how do you value these results in the context of current fecal staging system that does not require peritoneal washing since 2009? Do you think a positive washing is warranted for extensive adjuvant treatment like chemotherapy and external beam radiotherapy?
well, look, if you want, I can try to start to answer. For the carcinosarcoma, as Dr. Leitao said, for the serous, peritoneal cytology is important to guide the adjuvant treatment. In this case, serous carcinoma in the polyp with peritoneal cytology positive require adjuvant treatment. In this case, let's say that, as we said before, these patients are benefits maybe more from chemotherapy regardless the peritoneal cytology, while the radiotherapy is for local treatment, so local control. So maybe the peritoneal cytology can help to guide, let's say, the follow-up of this patient more than adjuvant treatment in this specific carcinoma histology. And regarding the fecal staging that is not included peritoneal washing status, well, this is maybe a next change for the next FIGO 2025, 2027 classification. Also, there is a paper from Mayo looking at the role of the peritoneal cytology also in the low-grade endometrial cancer. So there is something that we need to look more on this topic for the peritoneal role.
Okay.
Yeah, I
Mario?
mean, the removal of washings in cytology from FIGO is also, again, not quite based on the best data around there. And that was, again, expert opinion. For all you young folks out there, you have to get on all these committees and get involved with FIGO and GOG and NRG to really know how these decisions are made. And if after a while being in this field, you realize that it really comes down to a few strong voices voicing their opinions that then things get changed. It's not always because of the best science available. So I'm just going to tell you all that right now. And FIGO is not some all-being entity that knows everything. So just because FIGO says something doesn't mean that they're correct. All right, I'm gonna just say those things as like a soapbox. You have to really think through this and yourself and make your own assessments of the data and how best to treat your patients, okay? So there's lots of papers, including from our own, that show that washings, and even for low-grade endometrioid, we have another one coming out soon, I think, in IJGC. That shows that for stage 1A, grade 1 endometrioid, positive washing cases had a worse prognosis. Now, does that mean you treat them? We don't know. But if you don't get that information, we'll never have that information to know if they should be treated. And if you have sort of washings that are positive, that means you have free-floating cells in the peritoneum. So if anything, that would reduce your reason for giving pelvic therapy Why would you give local therapy when you have free-floating cells in the peritoneum, right? Your risk then is peritoneal recurrence, not, below the, I mean, think about it, the pelvis and the peritoneum are the same. So why are you just radiating the pelvis? I mean, it doesn't make sense for a disease that has a high risk of outside the pelvis recurrence. And you're giving patients toxicity and costs, not just toxicities directly from the radiation. And there's toxicities, but there's costs also and inconvenience. I don't know how many of you here can spend every day of 5.5 weeks going to get radiation for yourselves in your daily lives. I mean, you have to take that time off if you have a real job. So you have to really think about this. Radiation therapy is way overused in endometrial cancer of any form. And for carcinosarcoma, I really think you should never use whole pelvic radiation at all for treating this disease. Now, you might argue for locally advanced carcinosarcoma that you can't operate on and there's symptomatic bleeding. Sure, there's always going to be an individual situation, and there's no all or none for anything that we do. But in general, a stage 1 carcinosarcoma, there is zero data that you should treat with whole pelvic in any scenario, period, end of story.
Excellent. So following up on that same theme, Itzi Villagra from Spain is going to ask about another mode of radiotherapy.
Thank you so much for your presentation. Given that most recurrences were distant and the cohort included a heterogeneous mix of treatment modalities, do you believe that vaginal brachytherapy could reasonably be omitted in patients receiving chemotherapy?
Giuseppe, go ahead.
Well, let's say that as we said before, as Dr. Leitao said, the first and the main treatment that these patients need is chemo. Historically, this is the main point. Vaginal brachytherapy is for local control, and I mean, based on our data, we cannot say that this patient needs only chemo instead of vaginal brachytherapy. But the most important thing is for sure chemo. I don't know if Dr. Leitao wants to add something.
Yeah. Again, yeah, also to know how we are, where we are, and how to have conversations about treat these patients, you have to know the history of our diseases and how our field started and how these things were treated. The reason radiation is so ingrained in the care of endometrial cancer, I don't know if you all know, is that years ago, before surgery was as safe, the primary treatment was just radiation. There weren't any chemo drugs. You had Cytoxan that didn't work. You had drugs that didn't work back 50, 60 years ago. And surgeries were high risk because they were all done laparotomy, right? And high risk of infections. So at that point, it was actually safer to treat with radiation. And that's how radiation got so ingrained in the treatment of endometrial cancer. And now we just can't seem to get away from it. Now, local control is all that radiation does, no matter what form you give. IBRT, or external beam. All you're doing is reducing the risk of local recurrence, but you have zero difference on progression-free survival overall or overall survival. So you're treating, and if you look at the data for local control, the best is that you go from a 10% local regional recurrence without radiation. This is lumping all the trials out there. You go down to about a 4 to 6%, a 4 to 5, let's say 5%. So you reduce the risk of local recurrence by 50%. So you're going to treat 100 patients to help 5. That's it. You're going to treat 100 patients with radiation to decrease the chance of local recurrence in 5 patients. And then if no one talks about this with radiation, in those trials that looked at radiation versus not, in patients who recurred in a radiation field, their survival was worse, much worse, like not even close to being worse. So those are things you have to think about. And you have a patient also who's young. The 20+ year follow-up from the Alder study, which was a trial that no one really talks about anymore, there was a Dutch trial published in the 1980s. That was the first one looking at radiation versus nothing for unstaged endometrial cancers. They have now 20-year follow-up that shows that in women less than 50 who received whole pelvic radiation, they have a higher death rate. And why is that? It's because of secondary cancers. So you're treating these young, some of these patients might be, now with carcinosarcoma, they tend to be older. I mean, you're not going to get 40, 50, or, I mean, you can get 50s, but they're generally, the median age is like 60 something, I think, in our data set, right? So, or the mean age or whatever we put in there. So these are younger women, but in general, and we're just talking about general endometrial cancer, you have to really think twice when you have a younger patient, less than 50, who you're going to give them whole pelvic radiotherapy. You're actually reducing their life expectancy in the grand scheme of things. So keep that in mind as you all think about radiation and how and when and what type to use.
Excellent. So thank you for settling all those questions on radiation therapy so clearly, definitively, and concretely. Let's switch gears a little bit. Paula Mateo, let's talk about lymph nodes. Paula Mateo here at Methodist. Paula.
Thank you very much for the presentation. And well, based on what has been said so far, it seems that you're suggesting adjuvant therapy for this cohort of patients. If that's the case, would you consider omitting lymph node evaluation in carcinosarcoma, given that even the lowest risk cases of this disease still require adjuvant treatment?
That's a good question, actually. I think about that every time I do a serous carcinosarc, any undifferentiated. That's a very valid question. You know, as I've gotten older doing this, I don't know what Pedro's thoughts are, but you know, I'm really becoming less a fan of taking out lymph nodes. Definitely lymphadenectomies. It's a cool surgery. I can do them. I think there's a role for debulking maybe, but for staging, if it's not going to change somebody's treatment, what's the point, right? If it's going to, but if it might change the treatment, then there's a point to doing it, right? So you're absolutely right. If you're just going to give chemo, regardless to any stage 1 through 4 carcinosarc, does it really matter? Probably not. I mean, the risk, then you balance risk and benefit, right? The risk of SLN mapping is pretty low, generally speaking. It's not zero, but it's low. And the only way I can sort of just is that there is a prognosis impact. So a stage 3 carcinosarc will potentially do worse, but that's just prognosis. That might or might not help patients, but that's also will help us with knowing proper treatments. But also nowadays with the last IO therapy that included stage 1 to 3, and if they're MMR deficient, stage 3, non-measurable, they could potentially get immunotherapy. As well as if they have or HER2 new and they're stage 3, they could also potentially get trastuzumab. So it's a discussion. So, you know, you might have an impact on treatment decisions if they're node positive versus node negative, because you wouldn't do IO or trastuzumab, HER2 new therapy in stage 1 carcinosarcoma. Does that make sense?
Yeah, I completely agree with you. Again, I mean, as you mentioned, when you're not going to really be changing the recommendation for that patient, then, you know, is there any value in identifying a patient with a carcinosarcoma that has micromets on a sentinel lymph node or isolated tumor cells or even macromets? So yeah, I mean, I completely agree, but I think, of course, obviously, we all know that the standard still proceeds with sentinel lymph node mapping, at least in these patients. So we'll go now to Mo Byrne in New York City.
Hi, boss. I'm going to go a little off book if it's okay. Did
everybody hear Mario's comment? Mo, shouldn't you be at work instead of a coffee shop in New York City?
How baby. I'm actually, if I could, before I read my planned question, to go off of what you were just saying, if we're saying that the stage 1s are that high risk that they all need systemic chemo, while it's not necessarily like FDA approved indication, could you theoretically think about treating the earlier stage with an IO or adding a HER2? Like if we're saying, you know, there's not data for it, but if we're saying it's a systemic issue and a high-risk disease, the same argument could apply to giving those drugs.
Yeah, sure. That's a very good question and actually a very good thought. I think, you know, unfortunately, you'd have to do a trial that shows that it actually makes that hypothesis is real or not. So, and the problem is, you know, in the US, unless you have an FDA indication, insurance will pay for it, right? So you're not going to get approval for these things first.
It would be an interesting trial.
Sure, but as you can see, with 11 centers, we only had, you know, well, I guess it depends on what you're going to include. Is it just the non-invasive ones or just whatever, the stage 1s together? But yeah, you need definitely a multi-center, obviously multi-group, cooperative group type trial where you're going to, you know, in these earlier stage high-risk cases like this, you know, is adding IO also a value there? The problem is that they've done that trial already for high intermediate risk, you know, it was a B18 or whatever, I forget the number right now. The last one where they actually looked at quote unquote high risk endometrial cancers, which included stage 1, 2, 3 endometrial cancers that are non-measurable after surgery based on certain risk factors. Obviously stage 3, but then 1 and 2 are these risk factors, which included, I think, these histologies. And they found no difference for IO. Now, The problem with lumping everything together, which is the problem with using molecular information, is you're lumping all these things together, is that as a group, there was no difference. There was a difference for stage 3 MMR deficient in subgroup analysis, and that was it. But you don't know specific for these carcinosarcomas, was there a difference? Because there was only a small number of cases there, right? So yeah, they're included in there, and now the trial says that there's no benefit to IO, but is it IO for all those cases, or is it applied to carcinosarcoma also? And again, that's the problem with lumping things together when we know that they have biologies that are different. And we all know why we do that, right? When we do trials, because we need numbers to finish our trial. You know, if you're going to do a carcinosarc stage 1 only trial, it's looking at IO versus not. I mean, because the outcome is like the progression-free survival is like 60%. I mean, you know, if you can really have that hazard ratio improvement of 70, 65%, like you see with the other things, that actually wouldn't be as many patients you'd think, but you just have to find stage 1 carcinosarcoma. So, you know, that would be the issue, but that would be a consideration, and not to just lump stage 1 and 2 cases of all types together based on sort of arbitrarily decided what's intermediate risk or high risk.
Yeah. And even with not lumping, carcinosarc is still like a heterogeneous cancer on its own. I could read my regular question now. We don't have molecular or past data for this paper, but we know that P53 and sarcomatous overgrowth component have been associated with worse prognosis. It's unlikely that we're going to get the numbers to design a trial, but as we were talking about, if you were to design a trial, would you stratify by either of these factors or any other factors?
Well, yeah, you know my thoughts on stratification. I think people sometimes over-stratify things. Stratification is just to make sure that your trial has equal numbers of that particular variable when the trial's done, and not take the chance that there's uneven distribution. It doesn't make the trial any stronger. Okay, it's just all about randomizing and making sure patients are equally distributed in both. So if you have something that you really want to make sure you have 1-to-1 of that particular variable, then sure, you stratify or you can minimize. There's different ways to do that in a randomized trial. But there's actually papers looking at stratification that you don't want to have too many stratification factors either. That presumes that you know exactly what is impacting outcomes already. So some of these randomized trials that have 5,000 stratification, they're not better trials. They just make the randomization more complicated. So sure, we know that heterologous, homologous is different, right? So things that we know clinically already that have a big difference in outcomes. In a rarer tumor where your trial might be smaller or not, you'd really want to include that as a stratification, quote unquote, factor. And again, there's different ways of addressing stratification. In your standard stratification, there's different techniques, is what I'm saying. But yeah, and that's true for any trial. You want to really include things that you think could be hugely impactful on the outcome, to make sure that the 2 cohorts have equal distribution of that factor. That's what the stratification is all about.
Excellent. So, Mary, I'm going to read this next question from Joni Nouveau. She's at St. John's in Newfoundland. She couldn't be here with us, but she sent this question. Molecular profiling has become central in endometrial cancer management. So again, along the same theme. As you note, most carcinosarcomas are P53 abnormal. In your view, should histology like carcinosarcoma versus serous versus clear cell continue to guide risk stratification and adjuvant treatment recommendations, or should we start more fully relying on molecular classification? So yeah, again, back to that theme, because I think it's like what we constantly are hearing, right?
Yeah. Well, yeah, I mean, I could be here for hours if we have all that time talking about this stuff. But to throw out everything we've learned over 30 years to replace it with 4 molecular groups is very naive. I gotta be honest with you. What molecular stuff should be building on what we already know is important, such as anatomic stage. It should not be part of stage. You have anatomic stage. Stage tells you where the cancer's at, how much cancer the person had at the time you did your surgery or at the time you're treating, and then histology still matters. So, an endometrioid P53 probably does not have as bad an outcome as you think, and probably does not need treatment. And a P53 serous cancer is going to be worse than a P53 endometrioid. So I think what we need to do with molecular information is not replace what we have now, like many people are trying to do, but it's an adjunct, a further modification of risk for patients. So we have a lot of prognostic information right now, but do we have predictive information, which means, for those you don't know, when you have a factor, it can be prognostic or predictive or both. Ideally, you want one that's both, right? Prognostic means, all right, P53 abnormal, they do worse than P53 normal, okay? Now, the natural intuition is say, well, those P53 abnormal should be treated. Well, you don't know that. You don't know that intervening because they have a worse outcome is going to change that outcome. Now, if you have a factor that says if they're P53 abnormal and you give them chemo versus not, then that's predictive, right? So in P53 abnormal case, you give them chemo, they do better than if you didn't. Now you have also a predictive factor too, right? So, and that's not there yet. We don't have the predictive factors. And a lot of this prognostic stuff is a lot of these, if you look at all the data, including TCGA, none of many of those cases got treated. There's no accounting for treatment intervention effect. There's no accounting for any of that stuff. So you have to be very careful, which is a mistake that's being done by quote unquote the experts in the world, to use this molecular information to make such strong clinical recommendations. You just can't. I think we need to continue doing it. At MSK, we've been doing it for what, 10, 15 years. Every single one of our endometrial cancers gets next-gen sequencing. Not only do they get the IHC, they get next-gen sequencing using MSK Impact. So we think it's important as we learn more about this, but what I think, and I don't speak for all of MSK, I speak for myself, is that we are making the leap to using that as such an important clinical decision maker, and that's the mistake we're making. So yes, does a carcinosarcoma that's POLE, does that person not need treatment? We don't know that. We just don't. Because if you look at all the POLE cases in TCJ and everything else, how many carcinosarcomas are in there? 1, 2, right? Those groups are driven, the outcomes are driven by what the majority of the cohort represents. So POLE tend to be what? Endometrioids, low stage cases. They probably would have done well anyway, and they shouldn't be treated in the first place. So, yeah, and then the P53 groups, the P53 abnormals, what are they driven by? All your high-risk histologies mostly, right? And then you have a few low-risk ones in there, and then they just tag along. You know what I mean? You don't know if that really represents the outcome and the impact on a low-grade endometrioid cancer, right? So that's just for all you to think about. You have to be very careful, overly making such strong clinical recommendations based on something that we really don't know is predictive of intervention.
Excellent. So, Mario, we're going to go to a question from the audience, and I'll go directly to Diletta Fumagalli, who is at the European Institute of Oncology. Diletta, thank you for joining us. Do you want to proceed and ask your question?
Yeah, so can you hear me?
Yes.
I'm not sure because I'm in the car. Okay, thanks a lot. Thank you for the amazing presentation. So my question is again about surgical staging in endometrial cancer, especially high risk or aggressive histologies. So based on what you said before on lymph node sampling and peritoneal cytology, I was wondering if you see any value of taking an omental biopsy also in these cases, because again, this would not change or dramatically impact the adjuvant treatment. And thanks a lot again.
Thank you, Diletta.
So we have an abstract. One of my international fellows who's back in Ireland. He'll have an abstract at IJGC, I think. Maybe it was last time. I lose track of these things, guys. Anyway, we just looked at this very question in our high-risk histologies, which included carcinosarc, serous, undifferentiated, and I think clear cell. We had like 300 cases around there, maybe 286. I don't know, whatever. It's about 300. We looked at omental, and those who had an omental sampling of some sort, and we also had some peritoneal biopsy in there. Of all those cases, of those 300 cases, there was one patient with microscopic disease in the omentum, and that one person also had positive SLNs. So, you know, and we also had a complication from an omentectomy of a bowel burn, a transverse colon burn. So, you know, I actually have stopped doing omental biopsies. It's kind of random. Why I mean, think about it. You're doing a total omentectomy. You're doing just a little piece of the omentum. You're doing a gastrocolic omentum. All that stuff's at risk. Why is just a little piece of that fat hanging off such a risk factor for disease being in it? I don't understand that. It's something that we were told to do by our, you know, people who started our field 40, 50 years ago, because that's what they said you should do. But there's no data to support any of that. And then random peritoneal biopsies. What makes you think that you're going to find the peritoneal disease by taking a little pinch biopsy from 5 or 6 different sites in the peritoneal cavity? You have to do a peritonectomy to make sure you didn't miss anything. Plus, they're all getting chemo, right, for carcinosarcs. So who cares if there's a disease in the omentum, right? So having said all that, and having some data behind it, I have stopped doing omentum anything and peritoneal biopsies anything, and not only our carcinoma sarcs, but our serous clear cells also.
Excellent. Thank you, Diletta, for that question. Now, I cannot see any single reason why you would take any part of the omentum on your next case as well. So we have about quick 10 minutes. So Saniru in Mexico, next question.
Hey, Giuseppe, you take these, all right? I've talked enough.
No, it's okay. It's okay. No. I enjoyed the conversation. Yeah. And I mean,
Thank
I
you.
agree with you. Okay.
Thank you again for your amazing presentation, all of you. And considering that the study found no statistically significant survival difference between patients who did and did not receive adjuvant chemotherapy, how should these findings be interpreted, and what type of collaborative study design might best clarify the true role of adjuvant therapy in no myoinvasive endometrial carcinosarcoma?
Well, I will try to answer. Thank you. The point is, as we said before, and if you see just looking at the graphs, you can see that there is a trend of benefits, let's say a trend in terms of benefits in patients who had the chemotherapy. And the main reason that we have a small sample size, we have 58 patients with chemotherapy versus 35 with no chemotherapy. So maybe the answer to this question is just increasing the sample size may be a good option to try to find this answer and to find definitive conclusion on that. While, as we said before, trying to set a prospective multi-center registry, a multi-center trial in prospective way will help to collect more cases. But I think that historically chemotherapy works in these cases. So our results are visibly good, but not so good for the statistical point of view. But maybe increasing the numbers, it can be okay. I don't know if or something.
Yeah. So this is also, Journal Club to me is always talking about the statistics in trial design more than just doing a book report also on how to treat things based on this. This is how I run our fellows internal Journal Club. So this is a good point. In retrospective data, you have to be very careful if there's non-significant statistically when there's an obvious separation of curves. I hate saying the word trend because the trends can go all kinds of ways. Trends are like fads, they come and go, right? So you're very careful, but that more applies to randomized trials that had an upfront decision as to what was the important difference that they were looking for, and it was properly designed to find that difference. Now, if that difference is less, that's not my problem. Your trial's not underpowered. You said that 30% is what you want improvement. You found the 20%. Don't be telling me there's a trend. You didn't think that was important when you designed the trial. Don't be telling me it's important now, okay? So if you think that 20% is not important, guess what? Redo the trial and redesign around a difference of 20%. In retrospective, because you're just hypothesis generating, be very careful because you don't do power analysis on retrospective trials at all, or data, because everything's happened already. So you're just trying to hypothesis, just see what happens in your data set. That creates a lot of theory for future trial designs if you're going to do that. Now, when you do this and you see that the curves are widely separated as they are, and they're proportional, which is important too with Kaplan-Meiers, that they have proportionality, curves that overlap, you have to be very careful with what that means. But when they're proportionally, that means that there's a difference there. It's not statistically significant based on our cutoff of 0.05, and also 95% confidence included 1, which is more important. But in a disease like this, where you can make a hugely incorrect decision, okay? I mean, we're talking not only the PFS curves were different, but the overall survival curves look different. With a P07, P08, I would not feel comfortable with, only 97 cases. I would not feel comfortable saying that because the p-value is less than 0.05, you should stop treating these patients with chemo. Based on that goes into the whole thing that you can't just look at p-values. You have to look at all your data and look at what's happening. You have to look at the curves. How separated are they? How proportional are they? Hazard ratios are important, but that's just a statistical sort of effect size. What's the absolute difference also? I know that some people out there who are experts in these trial designs and doing all these big trials just focus on hazard ratios. You have to get away from that too. That's just one part of the message. If your absolute difference goes from 1 month to 2 months, that's not a clinically important difference either, just because it is significant, okay? If you measure in minutes, I can find lots of differences in benefits if I'm measuring survival in minutes as opposed to months, Okay, so you have to keep, so statistics is not the answer to everything we do. It helps us to understand our data, but it's not the answer. Okay, it's putting this all together. So you have to be very careful when you do a retrospective study. Now, if the curves are close to each other, then you'd say, yeah, fine, there's no difference, right? Or they're overlapping or something. But there's an obvious separation there. So I, even myself, as much as I hate trends and all that stuff, in a retrospective analysis like this, these data actually, to me, suggest I should keep treating my patients with chemotherapy, despite not having a p-value. And all right, let me ask, does anybody know where the 0.05 value comes from? Why is 0.05 so important for p-values? Anybody know? There's actually a history to it. Maybe one of you guys, maybe that'll be for the next journal club. Somebody looks it up and presents it. 0.05 is the reason that it's based on like agricultural studies that farmers are willing to accept a 5% error rate. I mean, that's all it is. That's it. So that's why p-values in some journals, they don't even want p-values because it's a relatively arbitrary cutoff. Okay. They want 95% confidence intervals. And if you have a 95% confidence interval, you do not need a p-value reporting. Everyone's so stuck on seeing that p-value. So if you're 95% confident, it tells you two important things. Does it cross 1? If it does, then it's not significant. And how tight is that interval, right? If you have a very tight confidence interval, that means your data are very good and that you're closer to the bullseye answer. If you have a very wide, that means you're just shooting all over the place, right? So that's why the confidence intervals are much more important than a p-value. You do not need, and some of the, IJGC is a great journal, of course, but many other journals don't even ask you not to put down p-values anymore. Major suggestion for Dr. Ramirez going forward. But the problem is that most clinicians are so hung up on seeing p-values. I think they don't get this point, and I think that showing a p-value is still the thing to do. We probably should still do it because your average reader is not going to understand that, and they just look, oh, the p-value, right?
All right, Mary. So we have about 5 minutes. We'll go to Matteo and Gemelli for the last question.
Thank you, and thank you for this amazing discussion. And probably you have already partially answered to my question. Considering the very low incidence of this particular condition, of this setting of disease, is it reasonable to assume that this is the best evidence we will have for some time? And how would you design the next study to try to improve this level of evidence?
Mario?
Yeah, I mean, I mean, the way to do this would be just to redo the same study and just invite more contributors. I mean, that's a simple answer. Because you're not going to do a randomized trial for 1A non-invasive carcinosarcoma chemo versus not. It's just not going to, I don't see that happening in any time, well, at least my time. But I think and Giuseppe and I can talk if that's even of interest, we just find 11 more sites and add to what we have now, potentially, to see. I mean, that's how you would do it. Of course, when you do repeated testing on the same data set, you got to do corrections and all that stuff statistically, but that's besides the point. So, I think that would be the next logical thing is, can we find I bet you if we had another 95 cases in here, you'd see in that p-value significant, you know what I mean? So, that would be the natural next easy answer. But as you all know, doing multi-center retrospective stuff with the IRBs is not always so easy as we make it sound. Giuseppe?
Totally agree with that. And also we need to consider that this study, the patient came from 1998 to 2023, and we get 97 patients. So if you consider this, it's a very rare, and so I don't see the space for a clinical trial. A multi-center registry, maybe an international registry, it's an option, and adding more centers and so on. But in this paper, as you know, Gemelli was in, all of these centers were main centers in the nation. So we need more cases, but it's going to be difficult to conduct even if it's a retrospective study. Sorry, it's difficult to difficult to collaborate with like 20 centers. Let's say like that. It's going to be very, very, very difficult. But yes, this is maybe an option to add patients. Thank you.
I want to thank you both, Giuseppe and Mario. This has been very, very productive and enlightening, and of course, obviously, always learn so much from you guys. thank you for the time. I want to thank also all of the fellows for putting together really fantastic questions. I want to thank everybody that joined us for this journal club. Really great opportunity again. The recording of today's sessions will also be available in IJGC, IGCS, and ESGO websites. And I also want to invite everyone for the November Journal Club that is going to be discussing our lead article titled Checkpoint Inhibitor Rechallenge in Advanced Endometrial Cancer, Revisiting the Immune Landscape Beyond First-Line Therapy with Brian Slomowitz. So once again, thank you all so much for joining us. Thank you for submitting your questions. Fantastic job all around. Fantastic. Thank you so much.
Bye, everybody.